today is about the importance of the muscle tissue as a metabolic regulator. So the contractile or skeletal or even striated muscle refers to the same thing. It's not just useful for locomotor purposes. On the contrary, it's a metabolic regulator with important functions being valuable for longevity. According to Mauro Di Pasquale, we carry our own fat, but our muscles carry us. This phrase implies the importance of the muscle tissue versus the fat. Now, the multiple role of the skeletal muscle, apart from the thermogenesis and stimulation of the basal metabolic rate, the skeletal muscles have abilities of critical importance. Striated muscles support bones and skeleton, improve the posture, and contribute to proper breathing. Intercostal muscles, sternocleidomastoid, serratus anterior, and levator scapula are respiratory muscles, along with the main muscle of respiration, which is the diaphragm, the dome-shaped muscle that separates the abdominal from the thoracic cavity. Now, the contractile muscle affect the protein metabolism because the muscles consist of protein and amino acids, and actually the skeletal muscle is a major pool of amino acids, a reservoir. So the role of protein is fundamental in order to support and consist the building blocks that participate in the synthesis of immunoglobulins A, D, E, G, and M. So we know that immunoglobulins are proteins, therefore muscles that are breaking down to the made of proteins are very important for the immunity. Skeletal muscles are able to synthesize to store 90% of the glycogen stored, which is the main fuel stores in the body, and a small percent deals with the liver. Now, the amino acid pool is responsible for the positive or nitrogen or negative nitrogen balance. These amino acids are broken down in cases of stress, such as starvation and malnutrition. Now, starvation is a form of physical and mental stress, and it kicks cortisol, the stress hormone, and the gluconeogenesis occurs. Now, the gluconeogenesis is a complex procedure that takes place in the hepatic parenchyma. The skeletal muscle is broken down to provide glucose as an acute energy source for the brain and for the muscle itself. During trauma, also, or burns, amino acids serve as an indirect energy source through gluconeogenesis. Gluconeogenesis equals muscle breakdown and catabolism, actually. That lowers DMR. This is catastrophic. This obviously equals to slower recovery and recuperation. Eventually, there is a poor quality of living, leading to wasting syndrome or cachexia. The lower the muscles, the higher the insulin resistance, and this reflects on the hemoglobin A1C. This happens. This occurs because muscle tissue is the number one metabolic regulator, and it burns glucose and fights glycemia. So the less muscle that we have, the more likely to develop insulin resistance and prediabetes. Now, during the andropause and the middle age crisis, this is the aging process that can actually lead to sarcopenia. The striated muscles are characterized by severe atrophy, minimizing in size. Andropause is a result of hormonal decline and reflects on how contractile muscles work. Cachexia leads to elevated adipose tissue, which in turn elevates estrogens and beta-estradiol in particular. Elevated estradiol increases also SHBG, the sex hormone-binding globulin that is antagonistic to the bioavailable free testosterone, the one that works. Therefore, we conclude, it's very simplified, but it's true, that the less muscle we have and the more fat we develop, the less the free testosterone, the sex drive. Now, the hormonal replacement therapy, both men and women, replaces the hormones, and in order to preserve the skeletal muscle and avoid wasting, HRT is necessary. Now, androgens in men, testosterone replacement therapy ensures there is no catabolic effect of cortisol because glucocorticoids and cortisol in particular is antagonistic to the androgens. So the lower the androgen, the testosterone, the higher the cortisol, which is catabolic. And after the age of 40, usually androgens decline and andropause equals the middle age crisis in men. It has been estimated that in middle-aged men the SHBG elevates, and this is mainly due to the lack of muscle mass that kicks on elevated adipose tissue visceral fat that also lowers the free testosterone. So, the low sex drive, these are the symptoms of the andropause. We have the low sex drive, low libido, plus the erectile dysfunction, that means the poor blood flow to the penis. Testicular shrinkage as well because of the low testosterone. And this is a classic symptom of the primary hypogonadism with testicular failure, with elevated LH but low total and free testosterone. The elevated LH reflects on the compensation of the brain to the lower testosterone and the shrinking of the testicles. We have, of course, as a result, lower muscle mass, strength, endurance, stamina. Lower muscle and lower BMI equals lower BMR. Increase of the visceral fat that leads perhaps to gynecomastia also, because gyno is estrogen related as well. Lower sex esteem and depression because of the lower DHT, but also because there is lack of optimization of neurotransmitters like serotonin, the joy hormone, and dopamine, which deals with the feeling of reward. The cognitive function is also linked with that. And another two things is the osteoporosis, osteopenia, that leads to bone fracture because lack of androgens. We have a lower bone mineral density, and the lower the androgens, the lower the APO, that reflects to the erythrocytosis, erythropoiesis, the synthesis of red blood cells, that lead to oxygenation of the skeletal muscle and the tissue in general. So we have lack of stamina and endurance and fatigue. Now men start to observe a significant loss in lean body mass and feeling weaker as muscles shrink and the basal metabolic rate drops. This eventually causes in more visceral fat, which increases estrogens, and estrogens is a negative feedback in the brain for synthesis of GnRH and LH that as a result increase testosterone. The less muscle will lead to insulin resistance, since muscles are the number one metabolic regulator of the body that burns glucose. Insulin resistance will lead to type 2 diabetes, non-insulin dependent. That also is linked to metabolic syndrome and cardiovascular disease. So we understand that lower testosterone may lead to metabolic syndrome and cardiovascular disease. The efficiency of the visceral fat oxidation becomes sluggish as testosterone levels drop. Now, testosterone synthesis must be by increasing positive nitrogen balance through assimilation of the animal protein. As we take testosterone, we are able to create a positive nitrogen balance through the assimilation of amino acids. Also stimulates aldosterone from the kidneys, which is a hormone that retains sodium and water as a result, that is able to lubricate the synovial cavity and smooth the pain in the joints. In this way, sarcoplasm is volumized and muscles appear fuller, toned, and this particular equals greater anabolism. After all, we know that muscles consume 70% of water. Nevertheless, it's also an anticatabolic agent that is the main hormone in the replacement therapy of the man. Here we have several forms of testosterone. We have the oil-based NF8 from Greece and CPN8 from the US, and transdermal testosterone of different concentration, 1%, 2%, and 10%. Now, this of the 10% is bioidentical liposomal. The other two were alcohol-based. Now, the DHT is a hormone that is reduced from testosterone, dihydrotestosterone, and DHEA, dihydroepiandrosterone, is a secondary androgen relief from the adrenals. Have a role also in the replacement therapy and improve the mental health, the cognitive function, the self-esteem, the sharp mind. DHT is metabolite of testosterone through the reduction by the enzyme 5A reductase, and kicks the free testosterone by suppressing the SHBG, which is the protein carrier of the testosterone in the blood. In the blood, we have two types of testosterone, the total and the free. The 98% is bound to the SHBG, but it's inactive, the total testosterone. So the real deal is the only 2% free testosterone. So you may have a good total testosterone, but the free testosterone will be below 50%. That means the total testosterone does not work. Now, the DHEA is released from the adrenals, and it has multiple effects, mainly for the immunity, but as an androgen also, it may improve the body composition, the EPO synthesis, and may have also an effect to suppress the HPG and improve the cognitive function and self-esteem. Speaking now about the muscle wasting, under autoimmune diseases like lupus erythematosus or the multiple sclerosis, but also other chronic metabolic diseases such as cancer, AIDS, or COVID-19, muscle degradation is something quite common. These cases are associated with chronic inflammation and lack of protein synthesis. Cachexia is characterized from loss of 5% of body weight from muscle tissue, and of course, the BMR drops dramatically. It is accompanied by a loss of muscle strength and endurance. Fatigue and anorexia are other symptoms, along with lack of muscle coordination. Laboratory manifestations that can show this case is elevated C-reactive protein, the interleukin-6, which is an inflammatory cytokine, and the low albumin, that means low protein synthesis, plus anemia, that means low hemoglobin. Now, how to fight the muscle wasting? Muscle catabolism is reversibly proportional to the BMR. The more muscle tissue we have, the higher the basal metabolic rate and the caloric expenditure. It has been evaluated that muscle wasting is mainly characterized from the loss of fast-twitch muscle fibers, the ones that you are able to lift. So there are plenty glycogen, which is responsible for the explosive activity, having low lactate threshold and are poor in mitochondria. They have a larger interaction that is able to transmit faster the signals. In other words, during muscle catabolism, we lose those fibers that are able to lift and have strength for bodybuilding, for instance. Now, how to restore wasting through nutrition? Patients who suffer from muscle wasting should follow a high protein diet, high carbohydrate as well, mainly in complex carbs, high caloric diet, plenty also in essential fatty acid, and rich in vitamins and minerals. Leucine is the most important BCA. It's anabolic because it's able to kick the mTOR, the rapamycin, which is the drive for the anabolic pathway. And glutamine, even though it's non-essential amino acid, is the most abundant amino acid in the muscle tissue, and actually during times of stress and catabolism, there is a lot of glutamine depletion in the muscles. So glutamine and leucine are really important. HMB now is a leucine metabolite, the hydroxymethylbutyrate, that is very important. And anabolic androgenic steroids are valuable under such condition. Actually, these were made for in order to treat the cachexia or muscle wasting, but of course under the guidance of a physician. And we need, of course, the stimulus, which is the resistance training necessary for the increase of the muscle tissue. So the stronger the muscles, the denser the bones, and this is explained why lifting weights is a major way in order to reverse osteoporosis, as skeletal muscles are attached to the bones. That's why during cachexia and muscle wasting, we have more fragile bone tissue. Of course, in order for the bones to strengthen, we need proper amount of the active form of vitamin D, along with calcium absorption from the food. Now, the anabolic androgenic steroids are agents that support the muscle wasting. The natural decaonate, known as decadrabolin, is a pharmaceutical grade agent, anabolic steroid, 19-orthotestosterone derivative. For the past 60 years, it has been extensively evaluated. And apart from the decent anabolic properties that DECA has, it has also 3 other properties. So to reverse osteoporosis, to reverse also anemia, but also to smooth the aching of the cracked joints. Not only is also capable of improving the stamina and endurance, this is a classic phenomenon of all the steroids because it kicks EPO. And speaking about the reversing the osteoporosis, this happens because it is able to improve the reabsorption of calcium in the renal tubules. Now, about the aldosterone thing, I said before that this is a fundamental way how all steroids work and retain water intramuscularly, that muscles appear fuller. But this also, even though it may kick blood pressure, it's very important for the lubrication of the synovial cavity, and it can mask the pain. It's not a healing property, but actually can mask the pain and lubricate the synovial cavities so that there's less friction to the hyaline cartilage along with the articular surface of the bone. Another good thing about the decadinandrolone is the low androgenicity. That means that also women can use it, of course, in moderate doses, let's say 50 milligrams every week or 100 every 2 weeks. All right? And it has less likely chances to develop hirsutis, acne, and voice deepening. Now, not only is it great anabolic agent, as we said, okay, it's a really decent anabolic, and anabolism, synthesis of muscle tissue, but also connective tissue is really important under trauma and burns. Connective tissue and muscles consist of amino acids, therefore, through a rich diet in protein, we can achieve a superb level of tissue healing. As muscles are strengthened from the resistance training, bones also become stronger and they attach to the muscle. We said that before. And the significance of lifting weights is well known in post-menopausal women that have to reverse the osteoporosis through lifting weights instead of just doing cardio. Another agent that is really important is the growth hormone. We know that it has anti-aging properties under minimal doses, lifespan properties, and it works synergistically well with testosterone and other anabolic steroids against the catabolic diseases. Now, GH favors anabolism by increasing the DNA synthesis in the tissue, making up new cells, and this is achieved through the proliferation of the cells by the release of IGF-1, which is the active form of the growth hormone in the liver, the insulin-like growth factor. Somatropin is the endogenous form of the GH from the pituitary gland that decreases with age, and we can estimate this by blood work measuring the IGF-1 levels. Low IGF-1 is linked to mortality, as much as high IGF-1 is linked also to cell proliferation, which is the basis, of course, of cancer and tumor growth. Optimized IGF-1 levels has various benefits against aging, including synthesis of collagenous fibers and connective tissue, improving skin quality, elasticity, arterial walls, joints, tendons, ligaments, and articular surfaces, and the proliferation of T and beta cells in the thymus gland. GH is a very good tool for the immunity. Also, there's an association between the GH and the levels of the protein that is linked to elongated telomeres and longevity. And GH, when it's combined to testosterone replacement therapy, DHT, esterolone, DHEA, and androlone, can become a powerful stack against aging and fragility that is associated with mortality in the elderly people. So that was my presentation, and if you have any questions, I'm here to answer them.
George, what is your recommended dose for HGH treatment?
Yeah, I believe for lifespan properties, we should minimize the dose up 2 IUs a day, preferably split it into doses of 1 a.m., 1 p.m. every 12 hours, let's say. We used to know that it was better to inject GH before night, but this according to some physicians, it interferes with the natural production of GH before sleep. So it's good to do it in the morning on a fasted state, because this fasted state with a low insulin level enhances further the beta oxidation, this is the main thing that GH does, burning fat in the first place. So before eating using GH, it enhances the fat burning property of the growth hormone.
Would you be better off using GH only in the morning to better make it work for the circadian rhythm and not use it twice a day, to just use your 2 IUs in the morning?
Yeah, this is a good point about the circadian rhythm. A high dose of GH is more likely to kick the IGF-1, that is linked also to muscle growth. But as I said before, we used to inject testosterone, growth hormone before we go to bed. And now the new protocol referred to do it in the morning. But I was not aware of the thing about the circadian rhythm you mentioned.
I've been reading a little bit about that lately, is looking at it from that perspective. What do you think of microdosing of testosterone?
Yes, microdosing of testosterone is a good protocol now. Actually, it's the old-fashioned way of injecting testosterone was every 21 days, 250 milligrams. And this is actually what the transgender does. The transgender do.
The way the transgender testosterone do it every 2 weeks. And
Yeah.
normal men do it every 3 weeks.
Now, the smaller the dose of the testosterone, the less likely to have fluctuations and the less likely to have spike of the metabolites of estradiol and DHT. We have more steady levels. And I believe that you should not inject less frequently than once a week. Some people do it every 5 days, okay, once a week. The point is that, let's say you inject on Monday, Tuesday and Wednesday you're gonna have a spike, you're gonna feel superb, and then during the weekend you're gonna have the trough levels. Some people feel that difference, others do not. But speaking about microdoses, using the cream is a perfect example of microdosing. And that's why the cream has the most stable levels, and does not matter which day of the week you are measuring the testosterone levels, because if you do, for instance, once a week, you have to measure the trough levels and not the day after that. Pseudo elevates, but it's pseudo elevated through the spike. So personally, I've tried injecting even every day 25 milligrams of. Some people believe that it's nerve-wracking, this and it's too much, and some others don't feel the difference every 5 to 7 days. All right, but this is the major disadvantage of the testosterone undecanoate nebidoravidone or Oravid, that every 90 days you inject, but during the 8 days, the last week before the injection, you feel horrible because of the low levels that drop. And also, when you inject a massive dose of 1 gram the first week, you super spike and you feel very agitated, and you metabolize the DHT and the estrogens climb super high.
George, given if a patient is using testosterone by injection, let's say twice a week, Monday and Thursday or something like that, let's say 75 milligrams twice a week, something like that, do you see any difference in the particular ester, whether it's CYP or enanthate? Really, would it matter given that frequency of injecting?
Well, CYP and enanthate have almost the same half-life, 70%. It releases, it's middle, well, we have the propionate also that releases 8%. But I believe cutting the week in half in 3.5 days is a good example of injecting, is a good case of injecting enanthate and propionate. All right, it's almost equal in time of release. And on the other hand, injecting propionate twice a week could be not enough because it clears the system faster. Yeah, so both of the, in the US and Canada, they mainly have propionate. In Europe, we have the enanthate. All right? But yes, this is also what I refer to my patients, to be is your protocol. It's Monday and Thursday, either Tuesday and Friday, or Wednesday and Saturday, cut the week in half. Do either 75 twice or 100 twice, which is the upper dose we may give.
Do you, I've heard some people say that they have a lesser response to transdermal modalities.
No, yeah, the transdermal has
Do you
the.
think that some of that is because of individual variations in the skin and the receptivity within the skin?
It matters a lot the area, the spot you apply, because usually doctors say rub it on your thighs, which most of the people are overweight and obese. There's a lot of adipose tissue there that is not absorbed. The late John Clisser used to say you should apply it in your wrists, or even obese people have thin wrists where the blood drops are made, and rub also your forearms to each other, and do not apply the palm because the palm acts like a glove. So wrap your inner surfaces of your forearms, and the other way, of course, is into the scrotum. Number one. Number two is the synthesis of the particular testosterone. We have the low quality alcohol based, and we have the high quality liposomal based. So we know, of course, that 90% of the transdermal is wasted. So that's why it's more expensive, because we only absorb 10%. In order to reach decent levels, this costs, because we lose 90%. Nevertheless, the liposomal bioidentical creams is the state of the art of the testosterone. I've used low cost alcohol-based testosterone that you have to apply a lot of material that costs eventually. Okay. And another thing, a third parameter, is the concentration. We have 1%, 2%, 10%, 5%, or even 20%. And in 20%, you just need a tiny droplet that does the job, okay?
Don't you think you see a little more aromatization with the transdermals?
I don't think so. And actually, what's the benefit, apart from the steady levels, is the reports have shown less spiking of hematocrit rather than the injectable, which is the main problem that almost everybody faces in replacement therapy, which is the erythrocytosis, okay, the elevation of the hemoglobin, and the frequent phlebotomies you have to undergo. I don't think that aromatization, because on the other, it's unlikely to aromatize when you apply a tiny dose every day instead of a larger, let's say, every 7 days, because of the spike of E2.
I have heard also, confirming what Doc just said, higher aromatization in a transdermal. For whatever reason, could that maybe be based on where the transdermal is being
Yes.
applied?
Yes.
It's because the hair follicles.
If you rub it, yeah, but I said if you rub it on your belly fat and you're a flabby guy, it's not absorbed easily, rather than in a vein surface like here.
Problem is, a lot of guys are hairy all over, and so because the hair follicle will convert a lot of it.
Also the scrotum, yes, that's why we say that we should shave off in order to be better absorbed. Dr. Hertog says you should apply it over here, the jugular vein, after you shave, because it's also thin the skin over here, and the jugular veins are visible.
With Dr. Hertog, or another
The
Belgian
forehead.
doctor because of the forehead, yeah. Other points, bizarre.
What's your opinion post prostate cancer patients?
Prostate cancer, no, this is a myth that has been fortunately debunked by the #1 urologist in the world, Dr. Abraham Mogetala from Harvard. Now, increasing the size of prostatic tissue is another thing, the benign prostatic hyperplasia. That does not mean that you're going to develop cancer. Besides, there is testosterone cancer, there is prostate cancer in men with low testosterone, because also estrogens are taking part in the proliferation of the cancerous cells. All right, so it's not purely androgen dependent, the prostate cancer. There was only one.
Well, she's
I
asking.
don't think it's awful. I think prostate cancer has nothing to do with testosterone, but the problem is the conventional wisdom is, that you should never treat a guy after prostate cancer.
But using testosterone while in prostate cancer, most actually the urologists say that it's putting fuel on the fire. Yes.
But how about hosts? Somebody's now treated for the prostate cancer and they're,
They have to closely watch out the PSA, and it has to be negligible levels, in order to be safer. I have a patient from the States. He's 60 years old. He doesn't want to do prostatectomy. He uses on a daily basis, but dutasteride is the most potent 5-reductase inhibitor. He just uses 100 milligrams of testosterone along with control of estrogens, so anastrozole also. But he wants to live fast and have sex with women half of his age, and he wants 5 years of life of a good, decent life quality, rather than taking off his gland. In most of these cases, when after the prostatectomy, the nerves down in the pelvis are messed up. That's why you have issues with erection.
Doc, there's a new school of thought on anti-estrogens, which is now that anti-estrogens are evil and the devil, and that under no circumstances should anybody use them. What are your thoughts on the use of anti-estrogens, or whether titrating testosterone dose before introducing an anti-estrogen would be maybe the better approach?
So personally, I'm controlling the estrogens with a small amount of anti-estrogens. Now, it's less likely to develop estrogens where your body fat is low. We need estrogens, of course, for bone health, for sexual function, also mainly for cardiovascular health, endothelium healthy. But too high estrogens can lead to gyno, can lead to clogging, and we know this from women with the contraceptive pills. So they are pre-thrombotic, and we have also the case of prostate cancer that having estrogens, and estrone in particular, is not good. But of course, crashing on estrogens is not good, so being paranoid. Now, the optimal range of estradiol, according to Rama claim, could be between 20 and 50, but this reflects on the total testosterone within the normal range. If somebody does a TRT of 250, which is not a TRT, it's more likely to aromatize, and you need more estrogen control, okay? And also, it depends on your protocol. If you inject 200 once a week, this will more likely spike in estradiol. If you do microdosing, the E2 will less likely spike, so you can avoid the implementation of the anastrozole, for instance. Certainly, estrogens are vital and useful, but people are complaining also of a lack of duration in the erection, all right, and bloating perhaps also, or itchy nipples that can be taken care of by Nolvadex, which is a tamoxifen, a serum, okay? Definitely the abuse of aromatase inhibitors leads to cracked joints, less bone mineral density, lack of sex drive also, and a reduction in HDL, which is the good cholesterol. We know that estrogens favor the lipid synthesis, and the elevation of HDL and the reduction of the LDL that are very important for the cardiovascular health. So I believe optimization is the key, and if you don't abuse testosterone, the less likely you're going to need the estrogens. Depending also if you drink a lot, if you eat soy, okay, if you have high body fat. So it's variety, it's multifactorial.
I think I've exhausted the
That's
question.
good.
I feel like I'm in a trial now.
Yeah, thanks. No, good.
I'm trying to have all the things that you want to talk about.
Yeah.
I'm trying to
Yeah.